Hey Mo,
Hey, Ricky.
happy birthday. It's our second birthday.
Happy second anniversary. Happy birthday to the doctor is in. And guess what? The doctors are in today. I'm here.
Doctors are in.
Dr. Alexia is here. We're so excited. We are talking about this month of March, this month of it being Minority Health Awareness Month. Did I get that right?
Yep, National Minority Health Awareness Month. Yep.
Well, every month is National Minority Health
It
Awareness Month
is.
for us.
It is. We need it every month. But we have a special birthday surprise. So I'm gonna let everybody check out our special guest.
All right.
Happy birthday to you. Happy birthday to you. Happy birthday. The doctor is in. Second birthday. Happy birthday to you.
Wow.
Yay.
Wow.
Happy
Wow.
birthday.
Wow. Thanks. Yay. Thank you so
Nice.
much. This is our new breasty friend who I brought into our sandbox. You know how I
I'm
do.
so grateful.
Maddie Green, and she's an amazing breasty story that she'll talk about, and she's an amazing singer. So look out for more stuff from her for us. So we've got Sheila Thorne, who's been fighting this fight with corporate America for 27 years, trying to get them to do the right thing. And we've got Dr. Alexia, who's been really fighting this fight in the age space, right, and trying to get this thing, and also being a breasty. So I'm gonna let you guys introduce yourself. We'll start with Madi, and then we'll go to you, Alexa, and then we'll get talking, and then we'll get talking.
My name is Maddie Green. I've been a performing artist for over 20 years, mainly musical theater, but I sing just about everything. Opera, I have an opera background. I was walking off stage in 2017 and something in my right breast had been nagging me, and there wasn't any discharge, there wasn't anything on the outside that would lead me to think something was wrong. It was just literally a nagging thought, and that was my first and last mammogram. About 2 weeks later, about 3 months later, I had a double mastectomy. I was grateful that it was ductal carcinoma in situ, which is stage 0. I didn't even know there was a stage 0. I was very fortunate that it had not gone into my lymph nodes. And that's where my journey began with what in that personal research, really having an eye-opening experience that these healthcare disparities were going on. I was fortunate that it was handled swiftly, but this just is meaningful to me that it's not handled swiftly. I tend to push my my way into places. So I don't know if it was me or if the situation, but I'm just grateful to be able to be a voice now that brings more attention to this specific subject.
Awesome. So glad you're here, and so glad you're healthy now. So glad you're here. Dr. Alexia.
Hey, everybody. I'm Dr. Alexia. I'm a triple board certified infectious disease physician. I'm a mom, a speaker, an author, a cancer wellness coach, and I am a stage 3 breast cancer survivor thriver. I was diagnosed with bilateral breast cancer at the age of 37. And unfortunately, my totally preventable breast cancer was 2 years in the making. I was known to be high risk based on a history of fibroadenoma dating back to when I was 21 years old, and then finding a lump at 35 that was LCIS, or lobular carcinoma in situ, and got thrust into the world of having a breast surgeon and a breast oncologist 2 years before I even had breast cancer. And multiple ongoing self-breast exams, clinical breast exams, mammos, ultrasounds, MRIs, and even a request to have a mastectomy later. I found out that I had stage 3 breast cancer by way of a screening MRI. And subsequent to my bilateral breast cancer diagnosis at the age of 37, I was diagnosed as being a PALB2 genetic mutant. So I did all the things: bilateral mastectomy, chemotherapy, radiation. I'm on hormone suppression therapy. And by the grace of God, you know, in spite of the disparities and in spite of the statistics, I'm here 4 years later. Sunday was my 4-year cancer diagnosis anniversary.
Awesome.
So I'm grateful to be here and be celebrating with you all and to just share my experience.
We are grateful to have you. Dr. Alexa, we're going to circle back and put a pin in that mutation conversation because
Yeah,
Mhm.
I don't know what that
Face-
means. Yeah.
right. And the face of what mutation carriers looks like often doesn't look like us. And it makes us think that genetic testing isn't necessarily something that impacts us or that is for us. And we need to really
Mhm.
talk about that as we talk about what action looks like in this space. But talking about
Yeah.
action, Miss Sheila Thorne has been taking action, making moves, taking space, pulling up chairs, pulling up whole tables. Tell us a little bit about your story and your background.
Well, thank you, and congratulations, and happy anniversary, happy birthday, whatever you want to call it. But I believe that what you're doing is groundbreaking. It's innovative. I'm proud of what you've accomplished. And these two beautiful, phenomenal women are proof that we can fight this, we can beat this. And so it's just an honor to be here. I have been doing multicultural marketing for the pharmaceutical industry for about 27 years, trying to enlighten them about our needs, unique concerns, and how best to reach out and engage us. And it's been a journey. I've unfortunately, in my family, have had touches with cancer. Father died of pancreatic cancer at the age of 47. My sister-in-law passed away from cervical cancer. And one of my team members of 25 years just passed away from leiomyosarcoma. So cancer affects all of us, and certainly of color, and predominantly women. But I'm so thrilled that Ricky invited me to share my experiences with you tonight, because I was part of the task force that got April designated as National Minority Health Month. I was with a medical advertising agency. I had the privilege of being on Dr. David Satch's advisory group, and he brought a stack of papers into one meeting, and it was the archived materials for National Negro Health Week that was started by Booker T. Washington. And he said, I think it's time we revive this and updated it and drew more attention to this. Does anybody want to take that on? So everybody kind of looked away, and I said, I'll do it. So I took all of the materials, blew off the dust, read through all of it, and decided that, yes, it's time for this. So worked with a team of people. We wrote the plan. We submitted it to Congress and got it in the congressional record. So April, from that date forward, was declared National Minority Health Month. And so it's been an awakening. And many of the state offices of minority health do a lot during this month, as well as the federal government. But at least once a year, we have the opportunity to focus on our situation with regards to an array of diseases that we are disproportionately hurt by, and preventable, treatable, manageable disease, but somehow that information doesn't get to us.
Right.
So
When was that, Sheila? When was that? What year was that?
oh my gosh, I was trying to think of it last night. It was in the late 90s, early 2000. That's when
Wow.
we had it designated. So
Wow.
it didn't get a lot of traction, but as I said, the federal government and the state offices have done a lot and still do a lot. Several states had already designated a month. Ohio was September. Everybody kind of did their own thing, but this kind of galvanized the country around at least this once a year to focus on this. Now, we've gone beyond using the word minority, but that's part of the month, so we still use it. But it's clearly an opportunity to take a step back and see just how much progress we've made. We have made some progress, but we got a lot of work to do. So my team focuses on at least helping the for-profit and the not-for-profit sector get their arms around how to reach out to people of color that get disease sooner, suffer more, and die younger, which is unacceptable in this country. So
Yeah.
I listened to patients like Mari and Dr. Alexia, and certainly Ricky and Dr. Mo, who really opened the dialogue, made it comfortable to talk about it. so that we can help and share it with each other, because that's the key to success. So I honor all of you, because this journey needs a lot of folks on that road. It's not the road well traveled, but we certainly are pushing the envelope, and it's our time to do that.
It is. Thank you so much. Thank you so much. And, you know, I feel like we're in the situation where everybody's talking the talk. You know, we're talking the talk, and George Floyd happened and COVID happened, and the talk got bigger. But I do feel like we're now getting these seats at the table that you have been fighting for and holding on. You've been holding on to that pork and that girl for many years at that table, but we're getting more about that. But I still want to feel the walk. I want to see the walk. I want to see people
Yes,
taking action and acting differently and doing things differently.
exactly.
And my
That's the
favorite
key.
quote, yeah, my favorite quote is Albert Einstein: "A problem cannot be solved within which the framework it was created."
Same mind,
And
that's right.
so when you start thinking like, well, this is what we did last year on, you know, in April, this is what we did last year on Black History Month. I don't want to do that. That's the worst thing you can say to me. What are you going to do differently to bring attention to these issues? And I think, you know, Dr. Elixir, you've seen a lot in the AIDS community. You've seen
Mhm.
happen there, and you know, talk to that about a little bit about what, you know, what's happened there, that people took action, you know, and we're now trying to make it happen in breast cancer. But I know the stuff that we're doing with One We Trial will hopefully have an impact in other diseases and get people into clinical trials and get attention to the drugs that we need, because our bodies are different.
Well, let's talk about that real quick. And Madi and Dr. Alexia, I want to pull you into this. What is your perception, I guess, of the breast cancer movement to date? You know, what would you say the average woman who doesn't, you know, follow the doctors in and who's not really working in healthcare spaces or dealing with this diagnosis, what do you think they understand or they see about what's happening in the breast cancer world?
I mean, I know that many Black women, Latino women, BIPOC women in general, don't perceive breast cancer as a disease that affects them or us, because we historically have not been part of the imagery. We have not been part of the campaigns. We've not been associated, you know, with the pretty pink ribbons. And, you know, and so that's coming from the outside. And then internally, we don't talk about those things as family units necessarily, or, you know, because again, the disparate healthcare, we just know grandma or great grandma died of cancer. We don't know which one. We,
Right.
you know, we
Right.
have these,
That's right.
you know, folk tales, but they opened her up and the oxygen hit and the
Cancer
cancer
spread.
spread, but we don't know what the cancer was. We don't understand that there's no truth in that. And
Mhm.
so we, you know, we don't, and we have this false belief that if the disease doesn't run in your family, who's,
not gonna
you know,
get it.
family history you don't know, you're not going to get it. You're not at
Right.
risk.
Yeah.
You don't need to worry about it. And we
Doesn't
have
matter.
such,
On my dad's
yeah.
side, I hear that all the time. What my
Yeah.
dad touched it, why does that matter? That's not important.
Right,
Mm.
right.
Mm.
So scary, so scary.
It is.
I
it
wholeheartedly
is.
agree with that. You know, my grandmother had a lumpectomy, but we don't know what kind of cancer it actually was, whether or not she had to have a lumpectomy. She was in her late 70s when it happened.
Mm.
I did get genetic testing. I don't have the BRCA gene, the BRCA gene, and I I felt like I think that I was under that sort of thought as well, that
Yeah.
you know, why do I have to do this? Why do I have to, you know, it really was like a smack in the face, even, you know, for me, because I thought that same way. I had that same thinking of like, well, why do I have to do this? And then it was like my mind being blown when I was like, this is happening, and the women are finding this at advanced stages. At the more I read, the more I got into that own personal research. So it's just not a discussion. It's not a
No.
discussion that we're having at home.
We're
And
not.
and that's, yeah, that's the, you know, I'm testament to that.
Mhm.
And my mother is she grew up in South Texas. She's Mexican, and even in her family, that whole side, she's had aunts, she's had, you know, nobody has that discussion outwardly as to what this is, because there's like a fear of it,
Mhm.
a fear of, well, if we talk about it, then
Like,
It's
like
gonna be
we're gonna
worse.
manifest it.
yes.
Right.
Yeah.
Ooh, that.
Will
Ooh,
happen,
can we talk
right?
about
Right.
that sort of
Mhm.
mentioning it means manifesting it. How do we
Exactly.
get around that sort of toxic theology? That's what I call it. I call it toxic
It
theology,
is. You're absolutely
Yeah.
right.
It is.
Mhm.
right?
It is.
But it
And
is.
but we hold so tightly to that as a people, you know. I
Mhm.
remember my dad, who's a prostate cancer survivor, whose father
Mm.
died of very aggressive metastatic prostate cancer, saying, I'm not going to no doctor so they could find something. I'm like,
Mm.
Daddy, that's the
Right.
point.
That's the
Is
point.
that if there
Right.
is something, you want them to find it early. And we as healthcare professionals, we can't find something that isn't there. But
Right.
isn't it better than to just
Right.
know that it's not there and to go and,
Right.
establish a relationship and a rapport with someone who can help you understand your risk, who's interested in your well-being? Because when we show up on the scene, not connected to any healthcare professional, and even sometimes when we are connected to them, they still fail us. But
That
when we
part.
show up on the scene with things really far gone, people already just have it in their mind. Well, they're Black, they do worse, it's more aggressive, they're gonna die anyway. I don't
Right.
have to try so hard.
Mm.
Right.
But
Right.
Dr. Mo is right though. There's such a stigma and a fear about yet something else that we as people of color have to bear as a burden, that you don't want to know the bad news. And the focus groups I've done around the country, I keep hearing that. If it doesn't hurt, then I'm okay.
Right,
So and
I have no
usually when it
pain.
hurts, you're in
Right.
bad shape by that
Right.
time.
I know by
So
that time, yeah.
yeah, you've got to cut through that by helping people to understand and putting a face to it, like Mari and Dr. Alexia, and certainly Ricky as well. Here's the lived experience. Okay, so you clearly have to make it real. And this is yet something that can be prevented or at least managed, and you can survive, and I think people don't think that's possible. Cancer is a death sentence.
Let
You
me
have
piggyback.
that, just
Mhm.
gotta lay down and it is what it
Yeah,
is.
right, right.
Let me piggyback off of that though, with the question of why don't we talk about breasts and why don't we talk
Yeah.
about sexual organs in our community? Is it a fear that we're going to further sexualize young women who are already sexualized, or is it because of our own discomfort because nobody ever told us what a breast exam was like, or because we only use euphemisms for things down there? We didn't
Pocketbook,
call it
purse.
your
Right.
cookie,
Mhm.
lots of
Yeah.
things, right? We didn't
Yeah.
call it what it was.
Right.
But
Mhm.
what is it about our community in particular that makes these conversations uncomfortable? And then how do we get there in a way that doesn't further sexualize young women and that doesn't shine more light, unwanted light on our body as something other than our own?
Well,
You-
I think it's fear. And I think
It's
that
fear,
what we
yeah.
learned from our research last year is that our level of literacy about most health, even the common cold, is zero. I mean, we don't know. No one has educated us about disease.
We want an antibiotic, don't we? We go
Right,
to the
right, one
doctor.
For that
antibiotic.
virus. Oh my goodness.
And we think we know what's wrong with us, but we don't really know. And we also, we just put a little Vicks on that, baby, you're gonna be okay. And we have
Lesson on it.
these old school remedies from our grandmothers, but we don't know enough. We don't
We
know
don't.
enough. And we're
No.
afraid to ask the question. So a lot of the fear is based on lack of knowledge. And we're proud, we are proud people. We got the
You're
purple
right.
cape, the crown. We're not gonna ask the question because we'll look stupid and we're not gonna let that happen, right? And
Yeah.
so we'll let the conversation happen and go over our head because we don't want to admit that we don't know. And then we have
Yeah.
more fear when we hear things that we don't really understand. And so that's why the education is so important. But the education has to come from us.
Yes.
It does.
Yes.
Has to come from
Yeah.
breast. When the white doctor tells you about it, it's like,
We don't receive it.
you don't receive
Right.
it. And so
Right.
unless we had, all the doctors were like Dr. Mo and explained it to you, broke it down to them for a Black woman's perspective, but that's not what's happening. And so that lack of education, lack of knowledge just turns into a blob of fear and complacency and not doing
Mhm.
anything.
And out there say it has more to do with just the skin tone, because patients will come see me and they'll sit there just like this and they see that white coat and they don't believe me either. And it takes a long time to build that
That
trust
trust.
and that
Yeah.
rapport. Because
Yeah.
the medical
Yeah.
community has really done a number on these communities, and it's hard to
Yeah.
overcome that perception.
Yes, yes, yes. And
Especially when you have the social media and the influencers and everybody telling you, the doctors are in cahoots with big pharma and they're hiding
Right.
the cure, and
Right.
they
right.
just want to line their pockets and all of these things. So even in this little black body, to some people I've sided with the enemy. So
Mhm,
it's like,
mhm.
Let me,
um,
wait, I want to
you
get
know,
Marty in here, and then I want to play devil's advocate and say,
mhm.
why is it though? Because this is a billion-dollar industry.
Yeah.
Why hasn't the needle moved forward more? But Marty, I want to talk about your perception about what we're talking about.
Well, I know that to be true. However, I graduated from high school in 1992, and I was a person that went to Planned Parenthood. I was a person who, my mother worked for a biopharmaceutical company. And
Wow.
so I got messaging very early, as far as like, you make decisions based on having as much information as you possibly can. But also at that time, there were a number of bills that had been passed about messaging about pap smears, about HIV
Right.
testing. Like it was coming out of a aggressive time where, the AIDS pandemic had really scared people into going to the
Having
doctor.
conversations.
And I was a young person. I was becoming sexually active. I was saying to myself, like, well, at least go and establish somewhere with a doctor that, what are you supposed to do? Like being able to ask questions. So that at that time, when I was 18 years old, someone was already talking to me about self-breast exams, yearly pap smears. It became part of my norm to every year go do that. I went off to college in Boston, and still in my head, I was like, I'm 3, 4, 5, 6 months late for my pap smear. I got to go. It would make an
Mhm.
appointment. And I think it has to do with it becoming a habit, and it becoming a habit that is, you feel safe in it. I definitely encountered people who were condescending. I definitely encountered people who were out and out, like just, kind of dismissive of me and my questions. But I also had enough other people around me that were like, oh, the discussion was there, the discussion, and with my girlfriends who, at that time when where I grew up, a lot of Caucasian girlfriends, they all were having these moments of talking with their GYN. So I had a circle, of discussing this. And then I was very open with my mother. My mother and I had that discussion, but still nobody knew anything like within the family. And I just feel like it's like these opportunities missed. Like, I even looking back, like opportunities missed to just ask my grandmother, ask my grandmother what it was, or where's your paperwork, like, so I can read it. But that I don't know. I don't know how to begin to heal that without it just becoming a habit, a mindful habit that has to change within our community.
Right.
A mindful habit that we begin to just say that we are, as a family unit, whatever that family unit is, we begin to,
Talking about
make it a habit. Make it a habit. Our healthcare is our well-being becomes a habit. And I'm one of those, I'm also one of those people who, you say to yourself, like, I'm just gonna go, I'm just gonna, keep working, I'm gonna keep, doing a show, just, I'll deal with that later. And you can't. Your body's at some point says, like,
No.
slow down.
Right,
yeah, we're
right.
shutting you down. We're shutting you down, right?
Yeah.
I think also for me too, a lot of it's for young women, it's about birth control.
Mm.
So you go to the doctor because you want the pill, right? Or you
Yeah.
want birth control. And so that sort of starts those conversations. But and I was kind of pre-AIDS. So, then sort of the AIDS epidemic hit. And then it was about, not about getting pregnant, but about protecting your life, right?
Right.
Yeah.
But
But
still,
it's just that's exactly what it is, though. It's like, regardless of from the healthcare provider end, right? Regardless of what the patient is there for, especially if it's one
Right.
of those, quick, easy, simple visits. Yeah, the temptation is just move on and get into the next room. But no,
Mhm.
take the opportunity to explore family history a little more. Take the opportunity to educate a young woman about breast health. Take the opportunity to tell someone to go home and talk with their family about their medical history before something comes up. And where are your parents?
Yeah.
Where are your, do you have siblings? Do they have a doctor? Send them here. That's what I
Yeah.
do with my primary care patients, and it's what I do with my HIV patients and my HIV prevention patients, my PrEP patients. I say, listen, if you're in here for prevention, that means your friends, the people you date, the people you hang out with and have sex with have risk. Where are they? They should be on
Right.
prevention too. Send them here.
Yeah.
And so it has to
Wow.
be the same for talking to a young woman about, breast health. Do your friends, go to the doctor? Do your siblings go to the doctor? Because when we're talking to young people, adolescents, young adults, we ask them, do you smoke cigarettes? Do your friends drink? Do you drink? Do y'all drink and drive? What does your social life look like? So why wouldn't we also ask them if they have a doctor? Do you all
Mhm.
talk about breast health? Are
Right.
you all getting your pap smears? Like, why can't we just take that 30 or 90 seconds to engage in that conversation? It would change lives.
I
Right.
like that, Dr. Alexia, because I'm sitting here thinking, what is the equivalent to the Know Your Status campaign, right? Because out of the
Mhm.
epidemic, it
right.
became a thing of knowing
Right.
your status. So
Right.
what would a
Mhm.
breast cancer campaign look like that is somewhat the equivalent? And I get that it's not equal because there's more things
Right.
to know,
Right.
but
Yeah.
what are some important things I think that we could convey in a campaign for people to know about their breast cancer risk?
Yeah. So, do you know your family's history? But also, do you understand that most women who get breast cancer do not have a family history? So, pretty much like if you know you are a person with breast, then you need to know that you're at risk for breast cancer. You need to know your body. You need to know your
Yes.
girls, know your lemons,
Know your
whatever you're
breast
calling
exam,
them.
right, right.
Right. Right.
Mhm.
Know
Know
your
your breast
normal.
density. Mm-hmm.
Yeah.
Normal.
Know
And
your
breast
normal.
density is becoming such a big thing. The data's coming out even stronger, Mo, about
Yes, it is.
dense breasts. And so, but
I
it's,
have
you
very
just,
dense breast.
yeah, you just
Mhm.
Black
gotta,
women on average do 31% more likely to have higher density breasts than white women.
right.
Mhm. Mhm.
And you're
Have
right.
heart
And knowing that family
cancer.
history is not
Right.
everything because many women, a lot of the young women who are watching, they don't have a family history. And then
Right.
there are some folks, when you look at the data of who is the most severely impacted by breast cancer, morbidity, and mortality, it is the Black, gay, and lesbian community. And they may not even have the connection to their family to know
Right.
that family history.
That's right.
So, where do we
And
go
they're
from
not going
there?
to the gynae, and they're not going to the gynae because they don't need birth
Exactly.
control.
Well, not
Mhm.
only that, because
Mhm.
they don't feel comfortable because
They
they're
feel comfortable.
misgendered, right? Because the
Yes.
doctors are you a he or a she or a them or
Yeah.
a shim or what are you? And
Yeah.
they don't go back.
Right. Right.
Yeah.
Oh,
Right.
It's so problematic.
Yeah.
It's so
Well,
problematic.
I think also the systemic, structural, and institutional barriers are pervasive. So even if you have the knowledge, even if you really want to go and get diagnosed or treated, people don't because the system is is so daunting. It's so foreboding. So
Yeah.
Yeah.
those social determinants, are the real
yes.
predictors of when you get
Right.
care, who gets care,
Right.
how you get
Right.
care.
How you get it.
And then you dismantle those barriers. It's going to be very difficult to encourage somebody to seek care because the
Yeah.
system is not user friendly.
No.
It's like the line in the book the sister wrote, 1619 Project. How do you love a country that doesn't show it loves you?
Mm,
I mean, you've got to get beyond that, and we can do it by having these kind of conversations. That
Yeah.
there's a
Absolutely.
Molly, there's a
I
Dr.
think
Alexia out there.
that's where you see that deep rootedness
Oh yeah, that mistrust,
that
distrust
we
is deep.
we're not caring for ourselves, and it comes
Right.
from that mentality of
Absolutely.
it being told to us for so long.
For so long, and not trusting because we haven't had that good experience. Disease
Right.
doesn't exist in a vacuum. It's in a cultural context.
Right.
Yeah.
And how culturally appropriate, relevant, competent are you? Can you treat people no matter what they look like, where they come from, or what language they speak? That's a whole different arena, and providers aren't taught that. You may intuitively get it because you're of color,
Mhm.
Right.
but you really don't know. And so that's off-putting. So you know what?
Right.
I don't need to do that. I'm not going back there.
Yeah.
So
Right.
So
And-
are we
and
starting to
good
address
experience.
this in 2022? Would you say pharma companies and industry and the medical community is doing better addressing language barriers, cultural humility and cultural sensitivity and all of these things?
Yeah, Dr. Moe, I've seen progress. They do what I call drive-by ethnic marketing. They just slap a black, brown face on a brochure and just throw it in the community. So that doesn't work, but that's a check the box.
Check
What
the
I
box.
have seen is
Yeah.
at least people are asking how. They're not asking why they need to do it differently. They want to know how much does it cost? How long does it take? When can I see results, outcomes, and
Mhm.
fruit? So they're asking all the right questions, but they're still struggling to get their arms around best practices and how to understand our lived experience,
I think
even
looking for
without disease.
looking for that ROI though, that immediate return on
Right.
investment is not the ticket. You
No, it's
know,
Well,
not
you're
the
absolutely right. And
the
and it's gotta
standard
be-
has been, the 5 has
gotta-
been the 10 for so long,
That's
right?
right. It's got to be qualitative before you can get to the quantitative. And that's what I tell. There's no relationship there. They don't know you. They probably can't even pronounce the name of your company or your drug. Okay.
Right.
So you're not going to this is not going to happen in 90 days. So there's got to be a
Right.
sustained commitment to show that this is part of your corporate social responsibility. I saw it
Right.
shift from the philanthropic humanitarian side to the commercial side of the ledger. It's kind of hovering in between now. They see it as a responsibility. They understand that it's their future in terms of organic growth from the business side, but they're not quite sure how to measure it, who to bring in. They want to find the Rickies, they want to find the Dr. Alexias and the Maras to give them guidance. That's why you all this patient journey talk, okay?
Right. The patient
Yes.
journey.
Are they listening? Are they listening and responding to that? That's where we have to hold their feet to a different fire. I certainly do. They don't like it, but it got to be in their face.
Yeah.
You gotta tell them their baby's ugly and do it with a smile, right? You gotta tell them their baby's ugly.
Hey, listen, you put the knife in and you twist it gently, okay?
Right,
So,
right. But I do think that some people I'm seeing more people with good intentions,
absolutely,
right? And
absolutely.
but intentions don't lead to actions necessarily, because
Right.
that's why they need you, Sheila, because they don't
Mhm.
know what to do. They don't know
Mhm.
how to talk about it. They don't know how to talk the talk. But I do think the attention to patients is making some headway.
Absolutely.
So it's a matter, do you take that patient journey and really learn something from it? And so
Mhm.
I think that's where we have to step in and say, hold on, wait a minute. You got the patient journey, but what happened? Well, what did that mean? Well, how did that
Exactly.
get from A to Z? What's the point of it?
It's an investment. It's not a cost.
No.
And that's a different
Right.
paradigm,
That's a
okay?
different- it is.
You
Putting that in
really
the
have to
chat.
reach into
Ooh,
these
that's good.
communities.
It's
Yeah,
an
so
investment. It's not a cost.
it's not a
Right.
cost.
Wow.
No.
Marty, you were going to say something. Go ahead, John.
Me?
Yeah.
No, I'm good.
So I think also, Sheila, you're dealing with the marketing people, the brand
Yeah.
people, that's my background. And
Yes.
so now I'm seeing there's like a conflict between the brand people that really have all the money to spend, right?
Yes, that's where the
And the
buckets are.
And the advocacy people who have like probably a tenth of the budgets.
Right.
I'm finding that now
Absolutely.
some advocacy people are reaching out to their brand people saying, hold on, wait a minute, and
Yeah.
kind of bring some more funding to the party. But also to your point, you cannot come in and have the party in National Minority Health Month, or have the party
No.
in Black History Month, or have the party on
Correct.
Juneteenth. If I hear Juneteenth again this week again, I'm going to shoot myself.
I feel the same way.
It's got to be a sustained effort in the community. We've got to see, you can't just come sponsor the NAACP dinner and not come back till
No.
next year.
Right,
With
right, right.
$25,000, right? So figure out how you're going to be there all the time with the pressure on, where there's
Mhm.
interaction and connection. And that's what we're trying to do with our funders, is like stay in their face, like, hey, this is what we did, this is what happened, like, and hopefully, they're starting to listen to us and support us. And when we try, we found that. So I feel very grateful and blessed for that. But
Absolutely. Well, you're relentless. I don't know how they could tell you no. I mean, but I mean, it's now at the CEO level, I see as well, that commitment, that top down piece, where before it was stuck in the brand or stuck in advocacy, and the budgets were so, minimal that it was almost a disservice to the community to even try something, because you alienate the population by your hit and miss.
Right.
So it's, and again, I think it's got to be permeated and woven in the fabric of how you do business.
Yes.
Yeah, it really
It
does.
doesn't have a home. That was the point that I
Yeah.
think Dr. Mo is bringing out. Advocacy's got a piece, brands got a piece, government affairs has their piece,
Right,
professional affairs, clinical research. Everybody's got to be in the room together to figure out how to divvy up that pie so that you can achieve the objectives that you're targeting. You can't do it as a silo. That's the
Right.
industry mindset,
right.
silos.
Silos,
Doesn't
yeah.
work. Doesn't work.
Twice this week, I have introduced the advocacy person and the brand person. For
They
two
never
different
met.
companies.
From
Right.
the same company.
Yeah.
Right.
Wow.
From the same
That
company.
same happens to me too. They
Bad.
come in the
Twice
room, we
same
like bring them
company.
together.
Twice
Yeah,
this week. Twice it happened this week.
it happens to me
I'm
all
like,
the
you know,
time.
so-and-so called me too. Well, I don't know them. Well, here you go.
But
And
you
y'all
know,
need to talk. Y'all
it-
need
it-
to talk.
It shows also the disconnect on their DEI efforts, right?
Oh,
Because
yes.
the
Right,
whole
right, right,
DEI,
right,
right,
right.
sphere really has to do
Right,
with not
right.
just, the external forward-facing campaign, but the internal corporate, collaboration
right.
and what we all believe about who we are as a company and what our
That's right.
purpose is. And that is
Exactly.
not good because
Not good.
that's so
It's
interesting to me.
it's a cross-functional
Mhm.
exercise, and I don't mind you making money, but don't make it at the expense of people who are vulnerable and marginalized,
That part.
put everybody in the pot, because even middle class and insured Black women and Black men have disproportionate disease. So what's up with that? There's
Right,
something else going
Right,
on there
right,
besides
right.
that insurance card.
Mhm.
Yeah, it's not just
Yeah.
the insurance, it's not education. I mean, we cannot educate our way, we can't earn our way, we cannot insure our way
on,
out
Doc.
of disparate healthcare.
That's
Right.
right.
Yeah.
At the end of the day, we're showing up in a Black or a brown body, and if the person we are seeing is not cognizant of the differences there, then it doesn't matter. All the insurance in the world does not matter. It's
And I-
not going to
Exactly.
change the outcome.
I think that's such an important point to shut down the respectability politics people. Those folks who are beating the drum. Oh, it's obesity. Oh, it's because they didn't breastfeed.
No.
Oh, it's socioeconomic status. It is not that is not the sum total of those things. And I
Mm-mm.
think we really got to separate the salt from the stew because there's a whole group of people who are just really reinforcing that trope. And it makes them not want to look elsewhere in terms of the science behind breast cancer for Black women.
Mhm,
Yeah.
mhm.
Yep.
That's
just-
that's their default. Yeah, or we don't have enough money to do this program. Well, how come you have $5 million to launch this campaign and you give the breast cancer people $250K? Who makes those decisions? Yeah,
Right.
how do you quantify to address the need appropriately? And you can't do
Yeah.
everything, but
can't do
whatever it is you
everything.
can do, give it up.
I think also too, I've been like, kind of saying the spend should be commensurate with the population,
Mm,
but that's not enough. The
no,
spend should be commensurate with the burden of disease.
correct.
See that Black women are dying at a 41% higher rate than white women. That, do that math and make that the number for what you spend on Black breast cancer.
Boom.
Totally
mic
agree
drop.
with you. Totally agree
Exactly.
with you. Definitely. Yes.
So we have a lot of work to do. So whose responsibility is it? I mean, we shout on the show every week. We're out here shouting every week. We're calling people. And when we're not on the show, we're shouting even louder, right? Because we're trying to be polite on the show and not curse you out, right? But at some point, we all have to play a role here. The pharma
Yes.
companies, the doctors, and there's so much implicit bias in the
Mm,
doctors that, it's so hard. Like we've been focusing on arming our breasties with information and trying to educate them and pump them up to be able to advocate for themselves and tell them what they need to know. But they're fighting an uphill battle when they go in that white doctor's office and he doesn't care. He
mhm.
doesn't treat them like family. He just has a hand on the door, as Monique says, and I'll see you by, I'm out. Here's the minimal amount of information I have to give you to get through my day, right?
Right.
And
Mhm.
so, I mean, until we kind of engage the medical community, I think we're have a lot of work to do. I think pharma is on the road. Pharma's
yeah.
they're on the runway. They're getting it because
Yeah.
people are dying. I mean, how do you
Yeah.
explain the death? How do you explain the death? Like you
Yeah.
can't,
Mhm.
like, you can't just ignore it, right? People are dying every day.
You know,
Yeah.
Ricky, it goes a lot deeper even than the implicit bias of race. It has a lot to do with the mental shortcuts that we're taught in medical training.
Mm,
For example, a
mhm.
young woman with a lump in breast pain, it's likely to be a breast cyst versus this is likely to be a breast cancer versus this is a zebra. This woman may have other risk factors. Maybe I should do additional testing here.
Mm,
And so there's this component to medical education, specifically for the doctors, that really needs to happen. That one gets them thinking about things in a different way so that they don't dismiss these women because
Right.
Mhm.
common things are common and uncommon things are
right,
uncommon in medicine. And we're
right.
taught you got to train quickly, you got to make decisions, keep it pushing. There
mm,
needs to be a pause button built in that says,
Yeah.
wait a minute, could this be a different or a unique circumstance? Why or why not? And the second
Mhm.
part has to do with research because pharma can come up with the best trials in the world, but if the doctors don't understand it, if they're not executing it, if they're not talking to patients about it, it's still not going to get across.
That's right.
Right.
That's
Yeah.
right.
And we
Yes,
and we
yes.
know with triple negative, they have no awareness of triple negative and how it affects
Mhm.
Black women. And now the treatments that we have that are miracle cures, we're seeing that every day. Have you heard about Keytruda? Have you heard about Trodelvy? Like go get the right drugs because they're just not educated about, they're not staying up on it and they don't care about Black women.
Yeah,
I
yeah.
think a
You
doctor
said
should
it.
see a Black woman come in the room and say, okay, I'm going to treat you differently because your burden of disease is different.
Exactly. Exactly. How do you see a Black woman and know she's more likely to die, more likely to be diagnosed at a later stage, more likely to have a more aggressive tumor and say, but I think it's a cyst. Like it
Right.
if you're talking about breast health or any cancer in any Black person, you have to be treating it the same way you treat chest pain. It's a heart attack
Mm.
until proven otherwise. Like
Mm.
to me, any symptom, any finding on a screening, etc., should be treated with the same urgency a heart attack would, or chest pain. Is it a heart attack? Let's rule out the thing that's going to kill you first, and then we can come
Yes.
back and talk about, is it a cyst or is it
Right.
something else, but
I love
to,
that. I love
to
that, Dr.
immediately
I love that.
dismiss it and say, no, it's most likely the benign thing in this most high risk person makes absolutely no sense.
Mhm,
And,
mhm.
we are smart enough as physicians and other clinicians to remember that data and say, I just have to do it a little differently here. I mean, at the end of the day, no matter what, you're clicking a button, you're writing some sort of order. So write the right one. If it
Mhm,
needs to
mhm.
be a referral for breast imaging, if it needs to be a referral to a breast surgeon, and if you don't agree or if you don't feel like they've taken it seriously enough, then make another referral. But
Mhm.
I love
we
that.
have
I love that.
to do
Assume
this
the
with
worst. Yeah, I think when
yeah,
you
assume
have a
the
breast
worst.
pain,
Rule out
especially
things
if
that will
she's
kill you.
37, 35, assume that this woman is going to die.
Mm.
So how would you treat her? Knowing that you make the assumption, start with she's going to die, and then work back to what her treatment needs to be.
That,
Yeah,
that puts
because
the
you
whole
can't
paradigm on its head. I got to tell you, that is so
you
contrary.
can't
love
tell a white
Yep.
doctor to treat it like you would treat their sister. Their sister's a white woman who's gonna
Right. Who's gonna
go
be
and
recovered.
get white
And
gloves,
recover.
best care service, no
Right,
matter
right,
her education, no matter
Right.
her
Yeah.
socioeconomic status. She's gonna have a better outcome than a Black woman
That's right.
because she lives and exists in a white body. So don't treat
Right.
us like you
Right.
would treat your sister or your mother. Treat me like I am the Black person that's at high risk and more likely to die in front of you. And
Right.
Yeah.
see it that way.
I love
But,
Mhm,
as
mhm.
we were saying, it has to be taught. Somebody who's been in
It has to
practice
be
for
taught.
20, 30,
Yeah.
40 years and has been told
Yeah.
repeatedly they're the best and everybody refers to them. They don't even have to make the effort. The patients are coming in droves because
Right.
they already have that title. They already have that reputation
Right.
in spite of our
Mm.
outcomes. So we
Right,
got to teach
right.
it early. We have to change that sort of mindset. And,
Mhm.
like we were saying earlier, like you beyond just the education, you have to get patients in front of doctors and student doctors. You have to put a story, you have to put a name and a face and a story that when
Mhm.
somebody is in an exam room 10 years from now, they're going to say, you know what, I remember that time.
Right.
I was in the classroom and I met that doctor, or I met that breast cancer patient, or we had that
Right.
symposium and we met all of those
Mhm.
patients. They're going to remember and see those faces and those stories more than the words in the textbook.
That's right.
It's true. It's true. Well, Black people are not white people with dark skin, and they seem to kind of think that. So you've got to go beyond
Yeah.
that layer. But there is a movement to have doctors culturally trained, if you will, if you can even do that. So there's at least an acknowledgement that there's a deficit, a cultural deficit in the healthcare industry, and that's interesting for people who have known this stuff for decades. You know, this is nothing new.
Right.
Say more,
but-
Sheila. Say
but
more
what-
about that movement.
Yeah, the movement really started with the unequal treatment report that came out in 2002, where Congress told the National Academy of Sciences, take a look at these disparities. You know, what's really going on there? And they took that study and they, looked at 18 months, they looked at hospital charts and talked to doctors and talked to patients. And they saw that there was a difference in how people of color were treated, even if insured. So there was something else going on there. And what they discovered was it was a lack of understanding the culture, where you come from, your life experience, how you live with being a person of color, and all of the issues that you deal with on a day-to-day basis, even without disease, what you're challenged with.
Right.
So that some states are requiring cultural training as a condition of relicensure. And it's kind of moving across the country. Anybody with patient FaceTime has got to have some kind of exposure to difference and being comfortable with difference. And so that's revealing a lot about how people really think about their patients, so, and I don't know about you, but I've been hearing all of this jump from health disparities to health equity. When did that happen? You know what I mean? You haven't even gotten the root causes of health disparities yet. And now you're saying you want everybody to achieve their optimal health. Well, how? You've got to dismantle some stuff before you can, get to that mountain of equity.
It's not wanting to have that discussion. It's not wanting to get deep in that discussion.
They're afraid to have that discussion because this country, we haven't had a racial reckoning in a long time. And the last time we
On
attempted
any
that in the
front.
60s, cities burned.
Let me
So nobody
jump
wants
in
to
and
go
say,
there.
on the part of medical educators, the AAMC, the American Association of Medical Colleges, has started to shift that language in an attempt to draw attention to the fact that it is the inequity that causes the disparity.
Exactly.
Because they're
Exactly.
trying to get people to understand. It's like saying burnout versus, corporate conditions that are not conducive to people's wellness. Right? You
Okay.
can put burnout on the person, or you
Right,
can say,
right.
though, the conditions are not conducive for people to be well in their workplaces. And so
Mhm.
they're trying to shift the language, but it seems to me that they've missed the mark. If your understanding of when you see health equity means we move past the disparity to the balance, that means
You
that
missed
whole
something.
campaign has missed the mark.
Exactly. I totally agree.
Yeah,
I
yeah.
keep hearing that.
Yeah. That whole
Equity is
concept-
it's an aspiration.
Right.
It doesn't
right,
appear like it's a realistic goal because you haven't even addressed disparities yet.
Right.
Right.
I'm loving this word, this concept of cultural humility. What is
Oh,
that?
yeah.
But you know what, if you think about it, you guys, who writes those trainings? Right? Who writes them? The people who aren't racist. Hello,
right.
right?
Yeah.
So to me, I want to do some research into how, like with a white male moderator moderating a focus group of white doctors, and get them to pull out the crap that they're telling people and get the words that they're using so we can then manipulate the conversation using their thoughts and their words.
Yes.
Because the people that are writing the training are the choir. They,
Yeah, exactly.
they are doing the right thing. They're not biased. So until we get, and also who's taking the classes,
Yeah.
That part. That
Right.
part.
right?
Right.
The racist white doctors aren't taking those classes. They're choosing the other classes they have to do to get their whatever certificate, right?
It's true.
Or they check the box and, now everything's virtual. You can just, Google the
It's
answer. on the-
true.
Get away with it.
And the
Yeah.
language, the vocabulary changes so much. We went from
Yeah.
cultural capability
Competency or
and
something.
competency
Yeah.
to cultural compassion to cultural humility, and
Yeah.
the
Yeah.
words keep changing, but the definition and the execution of what it means to
Mm.
understand and respect a person's culture, whether you call it competency, because you can't really be competent in someone else's
No.
culture.
No.
But
Exactly.
you can be
You can't.
humble
Exactly.
in the fact that you don't know what you don't know, and you can
Exactly.
treat that
And you
person with the
accept
white
that.
glove service that
Right.
they deserve. You start with the worst assumption about their health to get them to to rule out things that will kill them, right? That's what cultural
Exactly.
humility looks like. It looks like don't assume that
Absolutely.
everything is well without you working it up.
Well,
Yeah.
Dr. Mo, they're still stuck on, do you use
Yeah.
Black or African American? Do you use Hispanic or Latino or Latinx? I mean, give me a break.
Yeah.
So, I
Yeah.
mean,
Get
Do your
there, come
spiritual
on.
practices
Yeah.
affect your healthcare? Like,
Yeah, I mean,
no, being a
it's the wrong
Christian is not going to
questions.
affect whether or
Yeah.
not I had a mammogram or an MRI.
Although not being a
Bring a good
Christian may have
outcome.
some impact on whether or not you get the best care, right?
That's
Because we
true.
assume that
Right.
people who are wearing burqas and hijabs
Right.
don't necessarily want symmetry procedures. They won't do chemo. They won't take certain drugs. We make all kinds of assumptions about people
Can't
who
make
are
those
not Christian
assumptions.
in this country, and that
It's true.
too needs to
It's
stop.
true. It definitely does. And as you
does.
look at the populations burgeoning, for the first time, the census saw a
Right.
decline in the white population. And
Right.
the growth of this country is all people of color. So get with the program. I mean, I had one physician tell me after a educational session, I just want to treat everybody who looks like me. I said, okay,
Wow.
short, bald, and Jewish. What does that mean? I mean, it's just. I had to answer that way, Dr. Alexia, because of how ridiculous the statement that was. Didn't you take
Yeah.
something called the
Right.
Hippocratic Oath that said first do no harm?
That's
And
like
if
the
you were
people who
told
don't see
you-
color. I don't see color.
It just,
Yeah,
it just
really?
means
Yes, you
I
do.
want easy, I just want
Yeah,
easy.
it's not
I don't
comfortable.
want to,
Right.
I don't want to get to know anybody or
Mhm.
what their perspective on this American life is.
Mhm.
You're right, Mari. I've had friends in corporate America and in pharma companies say, this DEI stuff is great. I'm glad we're doing it, but it feels like a constant headache. It feels like I'm carrying this extra load. I said, really? Tell me more.
Right.
Yeah.
Imagine
Mhm.
They
living
roll
it.
their eyes when you
Right.
talk about
Yeah.
that.
And they
Yeah,
can
don't
turn
wanna
it
hear
off, right? They can
Yeah.
they can opt
Right.
out of that Zoom. They can
Right.
opt out of
Oh,
those
sure.
classes. They
Yeah.
can
Right.
take off that burden of
Mhm.
understanding the impact of one's culture and one's race on healthcare delivery in this country. But those of us who live it every day, we can't take that backpack off.
We can't. No,
And headache never
absolutely
goes
right.
Yeah. Yeah.
Well, that's the B, diversity, equity, inclusion, and the B is belonging. Okay, because if anytime people feel that you don't belong, they say, go back to where you came from. This is where I came from, the Bronx. I don't know what you're talking about. But I think, I mean,
You
I
might
mean,
have to take them back to the Bronx then.
hello, I mean, they get you in, but they can't keep you. It's like a revolving door because something's not right in that organization where you retain the talent who are of the populations you're trying to reach, It's an interesting dynamic, but we certainly are further along than we were 10 years ago. But so we know it's possible. I mean, COVID-19 showed us what global collaboration can accomplish. I mean, 2 years for a vaccine, unheard of, okay?
Unheard of. Right.
So what
Right.
happened there
Right.
that we can
Right.
duplicate
What
for
happened?
breast cancer and diabetes and all that other stuff?
And-
Something
yeah.
is missing. It's
Yeah.
doable.
It's doable. It's doable.
Yeah.
But it takes commitment, focus. And you know what? We got to break down the silos because
Yeah.
nobody can do it alone. I love
No.
that right now we're seeing Merck partner with Gilead and doing clinical trials on Trodelvy and Keytruda for triple negative. That is brilliant to me
It
because,
is.
put these scientific brains together to do better work.
Mhm.
But we have to, get pharma to break down more barriers, more silos and work together because, science is science. It gets better.
Exactly.
We have more brains and we need to see more of that. We need to see more even of our advocacy groups working together, like,
Mhm.
That's
and-
huge, Ricky.
yeah,
'cause
breast
everybody
cancer
has
has
their-
more, breast cancer.
Everybody has their silos.
Yeah.
Exactly.
Disease. And I have to come on, you want to come play with me? Like, let's do this together. Like, let's come up together. Like, I can help you, whatever. And I have those conversations every week and if they're resistant because I'm stepping on their turf. And
Yeah,
I'm like,
yeah.
you want Black women in your party? I can bring them to you. I can help you and you can help me with science or something. And it's a
Mhm.
struggle every day to do these partnerships with,
Yeah.
so. But
It's like
we
that old saying, diversity gets you in the room, but unless they ask you to dance, they'll get you to the party. That's diversity, but belonging means they ask you to dance.
Right.
I think
You know,
they
so-
want the diversity, but they don't want the equity.
No,
right?
they
They
don't.
They don't want an
Right.
equitable
They don't.
partnership.
They don't
Yeah.
No.
People want to be able to check a box and say,
Oh,
I
yeah.
did that. Bing.
I did that. I did the black.
did
I got the
that.
black
Bing.
thing. I did the black thing. Yep, I got the
We
black.
met our quota,
Right. Right.
Or I know Ricky,
having to
I know
change an
Ricky,
outcome.
Right. I know, Ricky.
Right. Yeah. Yeah. Like we cannot turn,
No.
I have Black friends into, I have Black patients or, there's Black people in my clinical trials. Like
Right.
it can't stop at
No.
that.
No.
And that's too often what people are trying to get away with.
Yeah.
And they
Yeah.
all automatically assume the poor Black woman, you know, she's
Yeah.
a single mom, she doesn't have
Yeah.
good insurance and
On welfare. Mhm.
yeah, on welfare. I had this, I spoke on this panel, SABCS a couple years ago, where with this white doctor dressed to kill, Black woman, white woman doctor. And she's like, well, I have gas cards. I can give people Whole Foods gift cards. I have all the stuff in my office. I said, well, how does the patient know that? Well, I don't know. Somebody knows where it is. Well, how many have you given out this month? She's like, well, I don't know. Like, we have a nurse navigator, but who's doing it? Like, how are you? Well, all people have to do is ask. I said, okay, I'm a poor, Black woman. Can you please give me the gas card? No way.
Oh,
Like, we had
please.
no concept of how that, how bad that was.
Dignity and respect.
Yeah,
It's just
yeah.
not
Yeah.
there. Yeah.
Yeah,
Look,
she
the
got
world has
knocked
not
off the
ever
table.
allowed us to be vulnerable. You
No.
think we're gonna, in the worst moments of our life, then go say, and can you help me with gas and groceries also too, please?
Right.
Mhm.
Come on.
Mhm.
Come
Yeah.
on.
Come on.
Yeah.
Come
Yeah.
While you
Yeah.
patting us on the back and telling us you want to be a strong Black woman just like we are. Because I
Right.
can't tell you how many times I've heard that. I wish I was a
Oh my
strong
God.
Black woman like you. No, you
Come
don't.
on, come
Yeah.
on.
Yeah.
You don't want
Yeah.
this.
That's a really good one, Alexia.
Like,
A
come
strong
on.
Black woman like
Come
you.
on.
You've been through so much.
Yeah, you've been
No,
through
but
so
you need
much. You're so
So much,
strong.
and you're so strong. Oh my God. Don't get me
Mm.
So
so.
how do we convince ourselves to lay down some of that strength in, or maybe not lay it down, but to repurpose it in the efforts of prevention, of education? Like, talk to the people who are watching, who are like, yeah, I am a strong Black woman. Yeah, I am due for my mammogram, but I got to go to revival tonight. I'm on the
Mm.
Right.
sport. I got to take the kids. I got to do
Soccer, I
da da
gotta
da da da.
dinner, yeah.
Right, right. We're wearing these capes, right? And on the one hand, we're talking
Mhm.
about being vulnerable. On the other hand, we're talking about being strong. Talk to the women who are watching, because we know that mammogram rates have still not gone back to
No.
pre-COVID numbers.
No.
We're still
Right.
seeing, I can tell you, I'm at this breast surgery conference, we're still seeing more women with advanced disease, right?
Mm.
Like, how do we pull people back in? Talk to the folks.
Right.
So one thing I learned is that, like, vulnerability is such a strength. To be able to say, like, I've bitten off more than I could chew, and I can't keep spinning all of these plates all day, every day. And I have to take a moment and step back, put some things down, put some things to the side, take care of me as best as I can. Because if I'm well, then my kids are well, my family is well, my career as well, et cetera, et cetera, et cetera. We have to take ourselves off the bottom of our totem pole, off the bottom of our to-do list,
Yeah.
and
Yeah.
make ourselves number one priority. And we have to be okay with that.
Mhm.
And so we have to shift mindsets.
Mhm.
And we have to do that by leading by example. Those of us who are out here in this advocacy space, we have to encourage our patients of that as healthcare professionals
Right.
and as professionals in general. Like, I think,
Mhm.
Yeah.
in our careers, right? If we see a boss who looks like us leave at 5 o'clock and say, you know what, this job is going to be here tomorrow, and I'm
Right.
going to spend
I'm
time with my
going home.
kids. I'm going to get my workout in. I'm going home
Mhm.
with
Woo,
time enough
preach,
to
Doc.
cook and prepare a healthy meal. Like,
Right.
if we all start showing up in that way, then the
Mhm.
rest of us basically have permission to follow, because
Yes.
we have been raised and conditioned that, if everybody else is giving 100%, you give 110, 150%. You got to come early. You got to stay late. You got to
Right.
work
Mm.
harder. You
Twice
got
as
to
hard to be
outperform
half as good.
everybody
Yeah. Yeah.
to
For
get
less
your
money.
60%
Over
paycheck
deliver.
compared
Yeah.
to everybody
Right.
else, right? And
Right.
so this is just the way we've learned how to be. We don't know any other way to be until
Mhm.
somebody else gives us permission to not be that way,
Amen.
So
You get
forget about
cancer
waiting
and
on
you can't
permission,
do
like,
it.
let's take it. But for me, I'm gonna just lead by example.
Yeah. Yeah.
Or you
And-
get cancer and you can't move, right?
And you, right.
Your peace is non-negotiable. I can't say that enough.
Right.
Marty,
You
what
got
does
it.
giving yourself permission look like to you?
I think it's taking time for yourself, giving yourself permission to take time for yourself. I'm guilty of not taking enough time for myself. I'm
Mhm.
guilty of that. Um, it looks like to me that it is whatever I choose to do, like whether it's like just sitting and drawing for a little while or coloring for a little while. Like, I think there's like a little bit of that, like, oh, you can't do that. You can't, there's cleaning to do, there's laundry to
Right,
do, there's
right.
those sorts of things to do. Going back to what Dr. Alexia was saying though, in that messaging, I agree with you wholeheartedly but in that messaging, there has to be also a clear description that the road could be exponentially shorter
Mm,
by early detection than by waiting, and I don't
Yes.
think that is
Wow.
clear. I
Yes.
don't think that is
Wow.
clear to us.
Yeah.
mhm,
That's
mhm,
deep. I'm writing that down in my mental Rolodex. Say that again. There
Mhm.
has to be a clearer understanding.
A clearer understanding for us that the road is exponentially shorter
Mm.
mhm.
for if it's things are detected early. If
Yeah.
we make
Yeah.
that part of our mindfulness, if we make that
Mhm,
part of our wellness being, and that
mhm.
and on our path moving forward, on any level, advocacy and medical, I think that has to be what becomes pervasive, that we're
Mhm.
doing this so that things can get caught early. We have bodies, they're going to change, they're going to do things, but we want to catch things early. And I don't
Mhm.
think that I knew that. I don't think
Mm,
like I think that I went through what the motions, like I told you, I went through the motions of what I was supposed to do, but I didn't
mhm,
understand why necessarily I was doing it until something hit me in the face that was like, oh, here I am. And
mhm,
by the grace of God, it's early.
mhm, mhm.
Um, you know, that, but it's tough. It's tough
It
with
is.
children. It's tough with a marriage. It's tough with a
Mhm,
job, and guilt on in each of those plates, it's
mhm,
tough to
mhm,
say like I'm gonna take time for this. I'm gonna go get a mammogram and get a coffee, and
mhm,
sit for a little while with myself or go to a
mhm.
movie, but just taking time,
Yeah.
Yeah.
taking
Oh,
some
I
time.
love that. I tell my
Yeah.
patients, make it social if you can. Maybe it's the one time a year where you meet up with your girls from high school or from
Uh-huh.
college or your other friend group where you get your mammograms, maybe you go for pedicures,
Mhm.
maybe you do something else, just sit, check in, catch up, like make that moment bigger than yourself and make yourself
Yes.
accountable
Yeah.
to and for someone else, because that accountability, like we show up for each other. We'll show up
Uh-huh.
at our sister's appointment before we show up at our own appointment.
Yeah.
It's true.
Right?
It's true.
Yeah.
Right.
We might need to reinforce that as well.
Yeah.
Mhm, mhm.
Yeah.
Whoa, 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 you guys. Oh my gosh. Much. So much to talk about. And Harper's marking. So much to talk about. I hate that we have to end this, but we need to do this again. We need to do this
Yeah.
again.
Definitely have
We
a
have so
part two.
much to talk about. We'll have a part two. We'll plan it, and we'll keep you guys in our butts, and we're gonna go to Essence. We're gonna talk about some of this at Essence, and
Oh, good.
Absolutely.
Good.
but we still have a special
Absolutely.
gift from Armati.
All right. I think it's perfect for the end of our discussion. And it is, to me, for me, worry and faith, that was what was revealed to me. Worry and faith could not exist in the same place.
Mm,
And I found myself singing this, but I find myself singing it now because it is so much more than just me. Oh, fix me. Oh, fix me. Oh, fix me. Fix me, Jesus. Fix me. That's all. I'm not gonna
beautiful. Beautiful.
Beautiful.
belabor the
That's
moment.
Beautiful.
enough.
Thank you for
Oh,
that, Steve.
Love it. Love
And
it.
people can find you on your
That's
website,
beautiful.
Mari, Mari Green at me.com.
At me.com.
Right? And Dr. Alexa, how can people reach you?
People can find me on Facebook, Instagram, and Twitter at Dr. Alexia, and my website is dralexia.com.
Sheila too, SheilaThorne.com, right?
Sheila Thorne, Sheila at SheilaThorne.com. Yes. Mhm.
Great. And you had to find me. I put my email in the chat and we can find these ladies, but you guys, part 2, we'll figure it out. All right,
Great,
we'll bring it.
great.
And thank you, thank you, thank you. You are such a blessing. I love you all so much. And
Thank you.
thank you for this big
2 years.
conversation.
Thank you.
Thank you.
Ricky,
I
happy
know, 2
birthday.
years.
Listen, I gotta say it because we've been saying it for 2 years. We hope this has been relatable and reliable and real. That's what we
There
set
you
out
go.
to do every single
Yes.
Wednesday night here on blackdoctor.org. Thank you to our sponsors. Thank you
Yeah.
to our viewers. Thank you to our breasties and everybody who is supporting this movement because it
Mm.
is a movement. Whenwetrial.org. Whenwetrial.org. The doctor's in.
Dr. Rusty love,
Okay.
Rusty love. Thank you so much. Blessings.
Be well. Stay safe.
See you
Bye-bye.
Thank you.
Blessings. See you next week.
Thank you. Good night, everyone.
Good
Good
night.
night.
God bless you.